Hello. The next patient is theater again. Next patient need to be
In another theater, we are planning to start the patient who is 55-year-old female who present with left side loin pain and found to
Can you
have
appreciate this just being formed?
real pelvic calculus.
Hello, Michael.
And starting was done. And Chandramohan sir planned to do flexible URS there.
Little out. It's on it. Hello, Lalit bhai. Andreas, are they? Can you please tell them to be with us? What they are doing here? Hello. Audio, please. Hello.
Yes, we can hear you.
Yeah, so you can see that this is the kind of a dust I want to make.
Yes,
This yellow stuff.
very nice.
And then what I'm doing is the painting over the stone.
Yes,
So I'm not trying to touch the laser fiber very much deep into the stone. And I'm using an extension tube for the irrigation with the 50 ml saline.
yes. So you hardly need any irrigation at this point in time.
Very
There's no blood.
going. Yeah.
Yeah, everything is great.
So the purpose is to convert this large stone into a very small stone. Once we reach to the center of the stone, sometimes it is difficult to produce very fine dust. Let's see what best we can do for this patient.
What is it?
The idea is that you have to produce a result as good as what you produce with the PCNL or a mini PCNL.
Yeah.
Okay.
Very nice. So, in the 10 years ago, they usually asked the anesthetists give Lasix. I'm not sure whether that works anymore. Now they have suction.
I generally do not prefer to use Lasix as when I'm performing a surgery.
Sure.
After I finish the surgery, yes, I give the Lasix because the other kidney will make a lot of urine and that will distend the blood.
Understood.
So I don't want to, and I go from the periphery to the center.
Yes.
You can see that I'm going from the periphery.
Very nice.
Okay, if I increase the power, this is such a soft stone
Yes.
that will be fragmented into multiple pieces in no time.
Yes.
But I think that such a size of the stone even if you take a lot of time, it will be hardly 20 minutes.
Sure. So it'll be high frequency for you right now. What's your frequency right now?
The frequency is 15.
15. And the other one is 0.4 times 15.
0.5.
0.5 times 15.
But you can see that I am not digging much laser fiber into the stone. Otherwise, it will break.
So that must be your favorite number, 0.5 and 15.
Yeah, at 0.5. And
We Chinese like 8 and 8, so you'll be 0.8 and 18. How about this? Very nice. You're doing very well. So I'm going to test you with a simple question. In quite a few Asian patients, I find that excess sheath in the virgin ureter is not so easy, especially for males. Well, especially thick and muscular in the psoas muscle. I find that the excess sheath is not so easy to put up, and usually in about 1/3 of the cases, I just pre-stand them and come back
It should face to
another day. But I guess logistically, it may be a nightmare for you and your patients if they live far away.
Yes.
But in Singapore, they live very close to us.
So in our practice, also we face similar problem when sometimes excess sheath is not going what to do. So you have to put double J stent as you do. But sometimes what I do is that I make an assessment of the ureter.
Yes.
I make an assessment of the ureter with the ureteroscope. If the ureteroscope shows that only the UVJ is a problematic, in that case I do a balloon dilation. Now some people have thinking that ureter should not be dilated with the balloon. But in my experience, I have done, I think maybe more than 1,000 cases where I have done a balloon dilation. And frankly speaking, I have not have any problem with
This appears small.
So I think balloon dilation of the UVJ is acceptable. And then probably you will be able to put a ureteral excess sheath.
Understood.
If you don't put it, then you can backload the scope also. Now there are all miniaturized scopes available.
Yes.
Like today morning, we were discussing about
QMET 6.2, 6.2 or 6.3.
6.2. So that I think in that case, you can just walk in like a ureteric catheter and produce a very fine dusting. And once you produce a very fine dusting, I think even if you don't have the ureteral access sheath. If the stone is small, I think there's no problem.
Yes.
But I don't want to go in the system when there is no ureteral access sheath, again in and out,
Agree.
and take out the fragments. Otherwise, that will damage the ureter, in the long term.
Yes.
So I believe that.
So in my practice, to save costs, if it's an Asian patient and I already suspect that maybe this guy needs pre-stenting, what I normally do, I just take out the instrument of rigid cystoscopy, and I put up a wire, and I do a sequential Cook's urethral dilators, and that's all I use. So if the Cook's sequential dilators tell me that I cannot put up access sheath, I don't even bother to open any other instrument. I just put a ureteric stent and I leave. And so the cost of the procedure is much, much less.
Got it.
Because nothing else is open on the operating table, I mean.
Okay. Yeah, take him. Take him. Come. Thank you, dear.
Yes, water.
Okay.
So, Michael, are you using a thulium fiber laser in your practice routinely, or still stuck to the holmium laser?
Flow will not be.
Right, I missed your question. I was sleeping.
Are you using a thulium fiber laser in your routine practice, or you do still stick to the holmium laser?
Oh, we have both. So it depends on what's available and whether any of my colleagues are using any other fiber. So I'll just carry on with whatever's available. Yeah. But
what is your preference?
I'm moving towards thulium. Yeah. But very low, a much lower setting than what the company is telling me. Everything they tell me, I drop it by more than 30%. So in the ureter, I seldom go beyond 8 even.
Yeah.
And then for the kidney, I look at time. If I have excess sheath, I go up to maybe 12. And then, but I have excess sheath. I look at my timing. I'm trying to keep the temperatures low. So it just depends on how much work is required. So if there's a lot of work to be done, and there's a slight difficulty in excess sheath, I put a DJ stent, and I don't waste money. I come back 2-3 weeks later when the ureter is so dilated, I can put a much bigger excess sheath, and that will help me stay longer doing a more complex case. So that's how I look at things now.
Yeah. So I agree with you, and we are using the same laser setting what you are using for the holmium laser for the TFL also.
Sure.
And in this patient also, my total power is at this moment is 7.5.
Yes.
The 15 plus 0.5, so it is 7.5. And you can see this laser is also equally, though it is a holmium laser, equally doing a good job.
Yes, it's very good.
And producing very, very fine dust as desired.
Yes.
So if you spend little more time in the operation theater, sometimes, all these PCNL guy, they will break it into 5 fragments and then take it out.
Yeah.
So for them, sometimes it becomes very boring to watch all this.
No. It's important that.
But I built that. I always feel that if you spend little more time in the operation theater, maybe 20 minutes more,
Yes.
You will send the patient home in the evening only.
Agree.
Without any complication, with a very clear urine and no problems. The patient can be back to the work very next day.
Yes.
So
the trick is to be patient.
Yeah.
When you're having a soft stone, you need to dust it. You just have to be patient.
So yesterday, when Andreas was telling that when he's cycling, he is doing yoga.
That's right.
For me, this is yoga.
Absolutely right. and it helps that you don't drink during weekdays. So every day you feel sharp and patient with your stones.
Yes, Sharak.
Yeah. So my alcohol intake has dropped tremendously over the years. Yeah.
So we have reduced this stone to half almost now. Now what we can do is that with the help of the scope, I can flip the stone little bit. If I can, in that case, again, I'll reach to the softer part. That I'll try to do it once I break it little more.
So at this stage, I would reposition the stone in the upper calyx to get it trapped there. What do you think about that?
I think I'm comfortable in this. But you can see the dust here in the upper calyx, all this dust. But I'm comfortable here, but you can do that. I mean, I don't want to use the basket to do that. Otherwise, I'll again spend a little more money.
You don't need a basket. You just puncture the stone in the middle, like you have this little hole.
Yeah. That I
and then with the laser fiber, you just lift it up there.
If the stone is hard, I can do it.
But you have a hole in the midst here.
Yeah, I can do that. Sometimes I demonstrate when I do the procedure like this. But in the harder stone, I puncture it in the center and then replace the stone wherever I want to put. So like this, I can push the stone. Even with the scope also, I can flip the stone up into. But I think I'm in a comfortable position. That's why I'm not doing it. But the suggestion is very valid. If it is a lower calacial stone, I think sometimes I do that. And if it's a small stone with a good infundibulum, yes, I will do that.
Is suction working?
Here I'm very, very comfortable producing a nice dust.
Now the PUJ is free. Oh, one fragment is there.
What do you think about the vision? And because this first time I'm using this OTU scope. How is the vision there? Here the vision appears to be very good.
The vision is excellent. The support services we're getting from this wonderful hospital is unparalleled. It's a perfect place to hold academic meetings.
Okay. Because now this is an era of a disposable scope. So sometimes I feel that all these reusable scopes, what we were using to begin with, they will go into the museum.
Yes.
So they served the purpose for a very long time. They are fantastic scopes, especially the Flexex C from Calstos and URF with from.
Excuse me, gentlemen. Now we are ready with the next case also, so we'll get the presentation,
Sure.
the description of Madhushankar, you can go ahead. You can introduce your next patient.
Okay.
I think we have to move on to a different theater. AV, we have to go on to a different theater.
Hello, sir. Hello.
Akshanka, you can tell, we can hear your theater, but we haven't got the picture, but you can start talking.
Make a share.